You see that? So what station is this baby at?
-1.
It's hard to tell, but I would say it's more like a 0 because it's pretty close to right at the ischial spines. Okay? If you said a -1, I'd be okay with that. Okay? Because it is just a little bit above. Again, it doesn't matter as long as we're making progress, right?
In the second stage of labor, the child is born. A healthcare provider usually encourages the woman to push to help the baby move down the vagina. She might push for minutes or hours. Once the baby's head starts to come out, called crowning, a provider guides the rest of the baby out. Childbirth is finished when the baby is completely out of the vagina. The provider then cuts and clamps the umbilical cord, which connected mom and baby during pregnancy. The last stage of labor involves delivery of the placenta or afterbirth. During pregnancy, the placenta supplies food and oxygen to the fetus. Once the umbilical cord is cut, the placenta has to come out. Contractions typically begin 5 to 10 minutes after the baby's birth. During this time, the placenta detaches from the uterus. A provider may encourage the woman to push, just as she did to deliver the baby. After 5 to 30 minutes, the placenta comes completely out of the vagina. Then the process is complete.
Okay, I was really hoping that was a different video. I actually had a DVD. I was thinking that was it when I started watching it, but that was a little disappointing. It actually animates showing the delivery, but I don't have a DVD player on my thing. So now we're going to talk about fetal monitoring. Before we go into that, a couple of things that I want to jump back on, and that is medications in pregnancy. Okay, remember what I said in that, are there any truly safe medications by FDA standards through experimentation? No, because we don't experiment on pregnant women. And remember, we don't want our mother to get dehydrated. So obviously anything that could potentially cause dehydration is considered not safe, okay? As well as, which includes anything that increases your heart rate, anything such as that. So again, what is one medication that you can think of that might be safe for a patient to take? Tylenol. Okay? So Tylenol, she can take as long as the therapeutic range is met as far as the limitations of it. Okay? However, little lanyard. Does anybody know who Dr. Corey Abear is?
Yes.
Very good. He's amazing. I love watching his show. Did you see it this weekend? Very interesting because it pertains to us and acetaminophen in pregnancy. So the new study shows, just came out, the research, actually the publication was last year, but he decided to highlight it on his show this weekend. So I was like, I better talk about it because it demonstrates a connection between acetaminophen in pregnancy and ADHD in children by a pretty significant amount, 20 to 28% in latter terms of pregnancy. So not significant in the first trimester, 20% significance in the second trimester, and 28% significance in the third trimester of pregnancy. So again, risk outweigh the benefits. This is kind of
What's
fresh
this guy's
off
name?
the,
Corey, what is it? I want to look it up.
the research on it. Just look up, Google acetaminophen in pregnancy. Because that's how I pulled it up. He had talked about the study. It was actually done in, I want to say, Norway. And so, again, we have to remember that. Again, as far as your learning, it's safe. As long as we stay within the parameters of, so pretty much what Dr. Hebert said was, you need to talk to your doctor. Okay? So, now again, I'm going to throw something out there about research. Okay, when I was doing my doctorate, one of the things that I had, a course I took had to do with ethics in research because I had to do a capstone project. And one of the things they highlighted was that somebody actually did a study on people who do research, and 50% of all people who they polled in this study admitted to having lied about at least one thing in their project.
I'm not surprised.
In their research. I know, 50% admitted to it. Okay, so again, we have to take everything with a grain of salt. I would say we probably need to duplicate their study before we start promoting that maybe there's a connection. I don't know if it has been duplicated, but even evidence-based practice, you take it for face value and make sure that it's duplicatable before you implement it into your current practice. Okay? So again, that's a huge big deal. And again, we also have to take it with a grain of salt because it was probably about 5 years ago that a research study came out that ibuprofen or NSAIDs was connected to heart attacks. Okay? Well, what do we know about cardiac disease? It's an inflammatory process, right? Cardiac disease truly is an inflammatory process. Who takes NSAIDs?
Cardiac
People
patients.
with inflammation. So can the connection really be in taking NSAIDs or the patients who would take NSAIDs? See, because they all have inflammatory issues. So wouldn't they already be at higher risk for cardiac events? So again, we have to use our knowledge because guess what happened at that time when that came out and it was reported? All of our little grandparents quit taking ibuprofen. So again, then we're not even treating the inflammatory issue, right? Okay, so we're going to talk about fetal monitoring. Does anybody else have any questions about anything and want to go back and talk about it quickly? Okay, so we're going to talk about fetal monitoring. Remember, this is the only way that we can actually monitor the baby is through fetal monitoring, okay? So we monitor the fetal well-being as well as contractions when we're doing external monitoring. In an internal, okay, so this would be an internal. We can do an external monitor for contractions and fetal heart tones, and we can do an internal monitor for contractions and fetal heart tones. Which one do you think is more accurate?
Internal.
Internal, because the external is just that little pressure button that I told you that we can actually manipulate. The internal is truly pressure being applied on the catheter that's inside of the uterus. So we measure contractions by how frequently they come, and we measure frequency by the beginning of one to the beginning of another, and how long they last. Okay? Each little box on the monitor is 10 seconds. So it's 10, 20, 30, 40, 50, 60, and you're actually counting how many boxes your contractions lasted. On an internal monitor, however, okay, and the external fetal monitor is picking up ultrasound waves. On an internal monitor, the catheter for the uterine pressure is measured in Montevideo units, MBUs. You don't have to remember that. Okay, but just know it's no longer just by how long it lasts, because we know exactly how much pressure is being applied onto that baby on an internal monitor by the Montevideo units. So how high it goes on an internal makes a big difference. How high it goes on an external means nothing. How do we know intensity of contractions on an external monitor? What'd you say? I thought you said that. Okay, the baby's heart rate can tell us when it's happening. Doesn't necessarily tell us how strong it is. How do we know how the strength of the contraction?
Mother's heart rate.
So the pressure. So how are we going to do that? How are we going to figure it out?
Feel it.
We have to feel it. The only way to know how strong the contraction is to palpate it. So we have to feel the contraction. So when all of you, I'm challenging all of you that if you happen to be in labor and delivery, you may not get to see a delivery, but you should be able to palpate somebody's contraction and feel it. Okay? So this is a, slight contraction. This is a moderate contraction. And this is a hard contraction. Her abdomen will feel this hard. Okay? So I know y'all gonna be in there. Okay, we've all done it. We're all in nursing school. So you want to palpate it and see how strong her contraction is. Okay? And that's the only way we can measure it. What's that? Okay, so this is a slight contraction or a small contraction, moderate, strong. Her belly's gonna feel like this. Okay? So I really want y'all to be palpating her abdomen and really knowing how strong her contractions are. Y'all didn't say it. Most of them say, well, ask mom. Well, that's fine, but I can tell you what's hard for you might not be the same for me, and she might have an epidural. Go touch her belly. Go touch your patient, okay? Again, we talked about who we don't want to do an internal monitor on, and I want you to know, an internal fetal monitor, an external is ultrasound waves. An internal is truly like a telemetry monitor. It is picking up electrical activity in the newborn. But guess how we do that? We screw on a metal screw into their scalp.
What?
We do. It doesn't go very deep, but we actually screw it into their scalp. So where don't you want to put it? On a soft spot, because then you have no protection. That goes, you know. And so who, other than, we know, somebody already said, somebody whose membranes are intact, we can't put an internal one. Who else would we not want to put an internal on? Who else would be contraindicated?
Maybe with a pacemaker?
Not
Mine's got an
necessarily, because
allergy.
again, this is really just picking up fetal electrical conduction. There's no electrical, it just, you know, is a way, just like putting on an external telemetry monitor on, all you're doing is picking up electrical activity. What other contraindication would there be to not putting on a metal screw into the baby's head?
Did they have like a head injury or?
An infection, especially what infection? Group B strep. Group B strep. Okay, because yes, we're treating mom, and hopefully treatment is usually considered adequate if mom gets 2 doses of antibiotics at least 4 hours apart, and the last dose went in an hour ago. Then the baby's no longer at high risk after delivery for getting group B strep. However, do we want to make it exposed to it by opening up a pathway in to where? The brain? No. So a contraindication for an internal monitor would be group B strep. You know, obviously other STDs, but hopefully mom's treated, because that's why we get those ahead of time. Okay, but group B strep would be a contraindication. So here you go. This kind of really gives you a visual. I love visuals on fetal monitoring, on fetal position. Okay, so your vertex presentation, head down. Hopefully baby is flexed. Occipital bone comes out first, so it's the mom's pelvis in relationship to the baby's occipital bone. If the baby has a mentum, which is chin, mentum presentation is when the baby's extended, and what's coming out first is the mentum.
Oh gosh.
Are we going to have a delivery?
No.
No. That baby's going to be a C-section, because can you imagine, is it ever going to extend around the pelvic bone? Probably not. Never say never, though, because when I used to do this, and I may even have it in here, I found a picture of someone delivering with a face presentation. It's amazing. So we might even have it at the end of this, okay? Obviously, then the breech presentation, that's your sacrum, okay? So does that help kind of understand fetal positioning and put that together? Again, why is it important to know where we're going to get fetal heart tones on mom's abdomen? So when we are doing fetal heart tones, first of all, we have to establish the baseline. And the baseline is the point of the fetal heart rate where it hits the most often. Remember, babies in utero, especially before they're about 32 to 36 weeks, are neurologically immature. Actually, it's more like 30 weeks. They're neurologically immature. So they don't respond like a term baby, meaning that they don't get as excited. Okay, so neurologically, they're more flatline. Okay, we don't want a baby flatline that's term, because a flatline means more like, now for us, our heart rate is pretty steady, unless we really go running or whatever. So, but a newborn, they neurologically are very stimulant, have a high response to stimulant. So their heart rate is all over the place. But we still have to know what the baseline is. And the baseline, you should be able to draw a line through a point of numbers that you know that this is where it touches the most often. Okay? So your baseline normal is what? 110 to 160. So you see that blue line? Kind of a giveaway, right? 110 to 160 is the normal fetal heart tone baseline. Now, again, immature baby, a premature baby, their heart rate might go at 170. Normally, the earlier in pregnancy, the higher the number. But by the time they're 30, 32 weeks, their baseline should lie between 110 and 160 beats per minute baseline. Okay? So that's the normal baseline. And this just kind of talks about it and when it might, mid-trimester fetuses are between 150. You don't have to know all the others. Just know that a baby that's more immature, earlier in utero, it might be a little higher. But your baseline should be the same for the same baby based on that age. Okay? So again, a baby's baseline at 40 weeks in labor, which is when we're monitoring her, should always be the same. So if it was 120 when she came in, the baseline should be 120 when she delivers. Are y'all with me? When a baseline changes, we have a problem. Okay? And a baseline is, if there's a change, whether it goes up or down, it's no longer it's not a change in baseline unless it occurs for at least 10 minutes. So we're going to have fluctuation going up, going down, but it's not a change in baseline unless that stays for at least 10 minutes. So tachycardia or bradycardia doesn't occur unless it lasts for at least how long? 10 minutes. Okay? But tachycardia obviously is if it's above 160, again for longer than 10 minutes. And then what can cause tachycardia in the fetus? Well, if mom has a fever, chorioamnitis, which is an infection in the chorion, fetal sepsis, medications, fetal hypoxemia, meaning that we've had a hypoxic event and the baby's trying to compensate. You can have normal tachyarrhythmias in newborns, which sometimes will continue after delivery because the baby just has an abnormal electrical conduction. Fetal heart failure, fetal anemia. So if a baby has an anemia in utero, which is possible, let's say the baby had a bleed, or let's say the mom had Rh factor, built up antibodies, one thing that might occur is she will attack the baby's red blood cells and will destroy it and cause an anemia in the baby in utero, okay? As well as maternal hyperthyroidism. So those are things that can cause a tachycardia in the newborn, or in the baby, in labor. Bradycardia, again, is when your baseline, now I want you to see this. You see how much fluctuation that is? But when you're how do you come up with a baseline with that? Like, how do you know what the baseline is? So it's, you see what I say? It's where the point touches most often. So you should be able to draw a line through your fetal heart tones and come up with a baseline. Are y'all with me? Do you understand? Okay. So, but a baby's heart rate will fluctuate. So what can cause bradycardia in the baby? Hypoxemia, again, drugs, maternal hypotension, hypothermia, hypoglycemia, fetal bradycardia, a heart block, congenital heart block or complete heart block, umbilical cord compression, amniotic fluid embolism, or just a normal variation. If this baby has been bradycardic since week 20, then that's just normal for them. Okay? Every once in a while you'll see that, not often. So for the most part, 110 to 160 is where this baby's heart rate should be. Okay? So, baseline variations, again, fluctuations of 2 cycles. I'm not going to get into all of this because we don't test you at this level. But again, variability is the change in baseline up and above and below the normal. We don't want a straight line. What I do want you to get from variability is that even though our baseline can be an indication of a good baby and a bad baby, variability tells us if our baby is neurologically intact. This alone, now the baseline matters, I don't want to take away from that, but this alone can tell you neurologically if this baby has had brain damage by a loss of variability. Okay? So I want my variability to be in the moderate range, which is 6 to 25 beats per minute. So it can go up or down 6 to 25 beats. That's a lot, right? That's a huge difference. And so, again, I want it to be moderate. A normal neurological function for this baby is moderate variability. Okay? So this is what moderate variability is, what it looks like on a monitor. When I've had loss of variability, what can cause loss of variability? Remember, this is the baby's response to stimuli. So what could cause more of a straight line? What do you think could cause that? and it be a normal finding.
Sleeping baby.
A sleeping baby, you are so good. I'm so proud. Yes, a baby that's sleeping. So during sleep cycles, a baby will kind of flatline because it's not being stimulated. So how long is a sleep cycle for a baby in utero? Anybody know?
Oh, that's all they do.
No.
10 minutes.
It does feel like it. It does feel like only 10 minutes too. 30 minutes. So a normal sleep cycle in utero is 30 minutes. If a baby loses variability for longer than 30 minutes, okay, we will give them up to 45 minutes, just in case, then we worry. So a loss of variability for longer than 30 to 45 minutes, we worry about. This is the baby we are going to worry about. Okay? Now, these cells we worry about too, and we're going to get into that. But remember, variability. Now, now what else can cause a loss of variability besides sleep, especially related to our labor patient?
If the mom got drugs, like pain medicine?
Very good. Stadol. So Stadol. And how long is it going to last? As long as it lasts for mom. So it could be an hour. Okay, so I'm okay if I had loss of variability after giving her Stadol. Epidural should not cause it because the epidural is not systemic. The epidural does not affect the baby. Okay? But Stadol will, and any other narcotics. Okay? You think her cocaine might cause her to have tachycardia and marked variability? And marked variability is when it's greater than 25. Okay? So again, medications will cross over and will cause that. This is what minimal variability looks like on a monitor. Do we want to see minimal? No. But we'll let it happen during sleep cycles and if we can account for it through medication that we gave. This is what marked variability looks like. Is it a bad thing to have marked? Not always, but I don't want you to just say, oh, how long can a baby be that stimulated and you not be concerned? Because usually it could be, look at me, the baby wants some attention, that something might be going on. Because right after that, you might see a D-cell. Or you may have seen a D-cell before and it's trying to compensate for it. Okay? So, the presence or absence of acceleration, again, that was variability. We have baseline and we have variability. We want to make sure that we have some acceleration. Okay? Because a normal fetus will have acceleration, which is your moments of, this is just minute to minute excitability. This is something good happened. So if I go and I do a vaginal exam and I kind of touch the baby's head, it should react by having an acceleration. Okay? And this is just, again, that it's neurologically intact. Okay? And it's just, the terminology for accelerations is whether or not it's periodic or episodic. If it happens while mom's just in bed and nothing else, that would be periodic. If it happens because I did a vaginal exam, that would be episodic. Okay? An episode occurred. So sometimes we have to try to stimulate the baby because we're not getting good acceleration, and so we'll use a stimulator, a vibroacoustic stimulator to see if we can get an acceleration. When we're talking about NSTs and contraction stress tests, this is what we're looking for. We're looking for, because you think a contraction is going to cause an acceleration in the baby's heart rate?
Yes.
Yes. Because this baby is responding to, oh my God, you're squeezing me, okay? We don't want it to have a D-cell because that means, oh my God, something's wrong, I'm not getting oxygen while you're squeezing me, okay? So again, when the baby's having contractions, we want to see accelerations. We don't want to see decelerations. And what we're looking for is if we see accelerations, okay, then it is the NST is reactive. And that's what we want, is a reactive non-stress test, okay, or stress test in the same sense. So, I want to make sure that we cover everything. So, now we're going to talk about decels. When we talk about fetal well-being includes all of these things. Baseline, the presence of variability, the presence of acceleration, and the absence of decelerations, okay? So we don't want to see deceleration. So there are 3 different decelerations by definition. And guys, I'm telling you right now, you not only have to be able to recognize them on the strip, but you have to be able to read the definition and recognize them by definition. Y'all heard me? You need to know both, because that's how important it is. You need to know both. So, the presence or absence of deceleration by definition, you either have a gradual drop in fetal heart tones from the onset of the deceleration to the nadir, which is the lowest point, and it has to be at least greater than or equal to 30 seconds. So anything less than 30 seconds is really just a variability, okay? It's only a decel if it lasts more than 30 seconds. Or you can have an abrupt drop in fetal heart tones from the onset of the deceleration to the beginning of the lowest point, that is less than 30 seconds. But again, it has to be significant. Okay, so we're going to talk about early decels. Early deceleration, by definition, is a visually apparent, so it has to be significant, usually symmetrical, gradual decrease. So it's a gradual decrease in the fetal heart tones. The nadir, or the lowest point, occurs at the same time as the peak of the contraction. So it looks like a mirror image. And all of these definitions are in your book. I want you to know that. And what causes it is fetal head compression. It is the neurological response to the head being squeezed into mom's pelvis. Okay? So does it reflect hypoxia? Does it correlate to a baby being without oxygen? The trick question, guys. No. It is truly only just a response of the head being compressed. The baby is still getting oxygen. Okay? So it's truly just a neurological response. So, is that a bad thing? Not always. Except, what if she's not even dilated and we're already having head compression? See what I'm saying? You don't have to do anything about it, but I don't want any decels in your mind to be absolutely okay, because even though it's a benign event, it's going to happen. If I'm already having head compression and mom's not even dilated, because again, that is pretty significant that this head is being pushed up against something. Okay? So again, it's a benign event. It doesn't mean you have to call the doctor. You can continue to monitor, but take note of it. The one thing I want you to know, and you're going to see this, is nurses sometimes will treat their patient by this monitor. Is that okay?
No.
No. So if all of a sudden I haven't been having early D cells and I'm having early D cells, what should I really go do?
Check the monitor.
Check my patient. And if it's head compressions, how should I check my patient? Do a vaginal exam. Let's figure out why I'm having head compressions. Because guess what? She might be ready to deliver. She may have only been a centimeter last time you checked, but she might be ready to deliver. Because sometimes that's our first sign of pending delivery, is these head compressions. Something is causing that baby's head to be pushed up against the pelvis. Okay? So, take it with a grain of salt. Early D cells are benign, usually no intervention required. However, you should at least go check your patient. Okay? Late D cells, however, by definition, it's still a gradual decrease with a gradual recovery. In the early, the fetal heart tones recover before the end of the contraction. However, in late, fetal heart tones do not get back to baseline by the end of the contraction. Okay? So, sometimes it starts, and usually it starts at the peak of the contraction, where you'll have the gradual decel, but the recovery back to baseline does not occur until the contraction is over. So the contraction ends, and my heart tones don't recover until after it ends. That's bad. Okay? This is a uteral placental insufficiency. This means that the baby is not getting proper oxygenation, and the culprit is in the malfunction of either the uterus or the placenta. Okay? Somehow there's not good circulation when we have contractions between the placenta and the uterus. It could be either that the placenta has gotten old and no longer functioning the way it needs to, or that the uterus is contracting too much and not giving enough break in between for there to be oxygenation recovery. Okay? My baby is hypoxic. And the longer I allow it, the worse it's going to get and the worse outcome I'm going to have. But it's uteroplacental insufficiency. You need to remember that term on late D cells and be able to recognize. So what are you going to do? Give mom oxygen. What else?
Examine.
Stop Pitocin if she's on Pitocin. Stop Pitocin. What else? Turn her on her side. So why do we turn her on her side? So there is an artery that feeds the uterus. And so when you never want your mom to be flat on her back, because that alone can cause late B cells, because that pressure from that uterus will close off that artery that feeds the uterus. And can you see a problem?
Oh, yeah.
Oh yeah. That's like clamping the cord,
Mm-hmm.
because you're cutting off all oxygenation from mom to her uterus. Okay? So what about a low blood pressure? Can low blood pressure cause lates? Yeah, that's not a vital organ for her. So she's going to preserve her own organs, and it's not going to be the uterus. So oxygenation is not going to go to the baby. So we can have lates for that. Again, placental uterine insufficiency, somewhere in there. So turn her on her left side. We'll get her off of that, and that's the best position for proper circulation. Again, hyperactivity, hypotension, hypertensive, a seizure, placental abruption, placenta previa. So what's the difference between, I know we haven't even talked about that, huh? So what's the difference between placental abruption and placenta previa? So placenta previa is when, I bet you can tell them all about it, huh? So that is when the placenta implants. The placenta is supposed to implant up and high, okay? So when the placenta implants low, sometimes it will cover the cervix, sometimes it's partial, sometimes it's complete. Can somebody deliver vaginally if they have a complete placenta previa?
No.
No, because once the cervix starts dilating, you're going to have detachment, okay? So, placenta abruption, however, is different in that it is where the placenta actually separates abnormally from the uterus. And what happens is it separates for whatever reason, and it starts bleeding, okay? So, do you think you're going to have pain with placenta previa?
Yes.
Not necessarily, because it's just about the implantation. So even as it separates, the blood, if it bleeds, is coming out. So you think you're going to have pain with placenta abruption? Absolutely. Blood is very painful in the muscle, okay? And blood is going to get into your muscle, your uterine muscle. You with me? So you need to know those two, and you need to be able to differentiate when your patient comes in bleeding in labor. Which one are they having? Which is more serious? The abruption. Because guess what? If that placenta completely abrupts, the baby's dead. And all you're trying to do now is save mom. Okay? And you do want there to be a tamponade. So if it's abrupted and there's nothing else you can do, you want her uterus to contract, because that's going to save her life, because the baby's probably going to die. Okay? Very good. So you have to know those definitions. That's when you're going to see, you possibly will see the late B cells. And what do? We already talked about it. We're going to check if she's hypotensive. We're going to fix her hypertension. We're going to discontinue pitocin. Somebody got that. Oxygen. Get the pressure off of her inferior vena cava, which is how we turn her to her left. And then obviously, if it's not fixed, we're going to go for a C-section. Okay? Hopefully, if we can identify the problem, we can fix it and continue in labor. Variable D cells are different in that, I want you to notice, it says an abrupt drop in fetal heart tones. Abrupt. The other two are gradual. This is abrupt. An abrupt decrease in fetal heart tones that are greater than or equal to at least 15 beats per minute, lasting at least 15 seconds. Okay? Each one of those boxes are 10 seconds. Both up and each one of those boxes, I think it's 2. Each one of the boxes up and down are 5. So it's 2 boxes down for at least a box and a half across. Okay, but it's abrupt. It's an abrupt drop with an abrupt recovery. The only thing that can cause that type of loss of oxygenation to the baby is the cord. The only thing that can cause it. What that means is that that cord is being cut off. Okay? The good thing is that as soon as we let off, oxygen returns. Baby recovers. So it's an abrupt drop with an abrupt recovery. Where's the cord? It could be up against the baby's head so that every time the contraction happens, it compresses it and then lets off. It could be that the cord is wrapped around the neck, so every time we push down, it puts pressure on it, cuts it off. It could be that the baby's holding it. The ultrasound mask, passed out, let go. That's so cute when it's yours. It is cute that they can have it, okay? So lots of things that can cause it, but the only thing that can cause that abrupt drop with the abrupt recovery is a variable, and it's because of cord compression. Nothing else can cause it. Okay? What do you do about it? You try to identify, I mean, it could be that the cord is in the area, so how about we do a vaginal exam and feel for a cord? You know, especially if it's really bad, okay, because it does matter how low it goes, because that does matter, right? So we can feel for a cord, we can change mom's position. Sometimes it's just that cord just kind of got onto her left side, so if we put her on the right, it pushes the baby's head down, just kind of frees that cord up, okay? So position change, we can give mom oxygen. Is it going to help? But it can't hurt, because the more oxygen to mom, the more to baby. But we need to figure out where that cord is and kind of fix it. Okay? Sometimes you can, sometimes you can't. It can get quite stressful when you keep having these D cells that last that long. Now see, does it have to be related to the contraction? No. Just like that baby cutting off its own cord. That had nothing to do with the contraction. So it can be related to the contraction, or it might not be. Again, prolonged, you may hear that, probably not on a test, but prolonged means that it lasted for more than a minute, okay? So is a prolonged. Again, prolonged can last how long? 9.9 minutes, 50 seconds. Because at 10 minutes, it's now bradycardia. Y'all with me? Okay. Hopefully it doesn't last that long, because that would be very stressful and you're probably going to be going back for a C-section. But again, it can last up to, and it's still just a prolonged deceleration until it hits 10 minutes. And then it's bradycardia. You with me?
Is this PowerPoint going to be on the end?
What do you need to know about this? Because there's a lot of information on here. What you need to study when it comes to it is understanding the different aspects of fetal well-being and recognizing the type of D cell and being able to say, based on that D cell, what's wrong with it and how am I going to fix it. That's what you need. Okay? But I'm telling you, you not only have to recognize it, but you have to know the definition.
I mean, you say recognize it, we're going to have to like look at one of the strips and...
Maybe. You might have a strip on there, or you might have a definition, okay? So you may be asked what type of D cell it is, or you may be asked, what do you need to do about it? So you have to be able to know what type of D cell it is to know what to do with it, okay? And again, it could be a picture, or it could be a definition. It's that important though, guys, because that's the only way we know that our baby is safe. That's it. You still are going to have them on NCLEX. So for at least one major test after this class, you're going to have to remember this stuff. Because I can guarantee you, you may be given a type of a D cell and have to do something about it. And remember what I said that students tell me? That, oh my God, there were so many labor and delivery questions. Well, guess what? It's because you didn't learn it and put it in your brain. You just learned it for the test. But you're going to see it again. So it's that important. And it's not pediatric questions I hear about. It's labor and delivery. So unfortunately, we compete in how much time we have. I don't know that it would make a difference if I had more time, but because I don't know what's on your NCLEX, but I know you're going to see labor and delivery questions. Okay? So, again, what do you do about your variables? We kind of talked about that. We need to just get the cord off. Again, this is what a prolonged D cell looks like. Whew, don't want that patient. Hang on a minute. So this, So this is a way, look, I'm all about visual, so hopefully this will help you visualize what's going on. So your earlies, head compression. Think about that baby in the clamp. Your lates, uteroplacental insufficiency, you need to turn your patient, put her on oxygen. And then variables, always remember cord compression. Okay? Again, it's all about intervening and making sure our baby comes out neurologically intact, okay? And I could tell you some horrible stories, but I'm going to save you. So, what do you need to know about contractions? You need to be able to identify their frequency and duration. So know that. Frequency is from one to the next, and that's how you measure it. Duration is how long it lasts. Each one of those is 10 seconds. So I'm physically counting boxes in labor and delivery to say how long my contractions are. I usually use a range. Baseline, I'm giving a baseline of a fetal heart tone, 120. I can't give 120 to 130. We used to be able to do that. It was 120. But my contractions, because they're not all perfect, I'll choose the smallest one, the one that lasts the least amount, and the longest. And so when I'm actually filling out contractions, it's a frequency or a duration of 30 seconds to 60 seconds. Okay?
And each little box is 10 seconds.
Each little box is 10 seconds. Okay? So, and then I count my longest and my shortest. Or, then I count my closest together and furthest apart. So, it could be every 2 to 5 minutes, because I might have 2 contractions that occurred 2 minutes apart, and then I might have a couple of contractions that occurred 5 minutes apart. So my contractions, or the frequency, is 2 to 5 minutes apart, lasting 50 to 60 seconds, or 30 to 50 seconds, okay? And so that's how I'm going to document my contractions, okay? And how am I going to document how strong they are? Palpate, okay. Unless it's an internal and that's a whole nother thing. So this talks about placenta previa so that you can have your visual on what it is. It's where the placenta actually covers the opening of the cervix. You can see how that's a problem. Okay? And then this is an abruption. So you can see it can be a partial abruption, a relatively concealed abruption, where the partial abruption, you're probably going to see bleeding. Okay? Is it going to be painful? Yes. Is that placenta previa going to be painful? No. Concealed abruption is where the bleeding is behind. And so, again, as long as it tamponades itself, sometimes that pregnancy can continue. And the bleeding will be reabsorbed. What do you need to know? You need to just know how to identify each one in a patient. Okay? And so, let's take 5 minutes, and then we're going to come back and do postpartum.